Okay, hello everyone. We are going to move on to disorders that have their onset in adulthood. Gotta wait for my program to load. Everything's a little slowed down today. These are a little bit different than disorders of pediatric onset, which tend to involve genes that always express themselves. With the adult disorders, sometimes there's an environmental trigger that has to turn that trait on. So, our learning objectives, we are going to discuss genetic and environmental factors that affect the expression of monogenic or single gene disorders, including alpha-1 antitrypsin deficiency and hereditary hemochromatosis. Then we'll move on to talk about diabetes, very complex disorder. There are several types. We talked about type 1 in pediatric lecture. Now we're going to talk about MODY or maturity onset diabetes of the young, and diabetes mellitus type 2 and how they differ. MODY is actually a monogenic disorder. Diabetes mellitus type 2, very heritable, but we're not exactly sure how many genes are involved. It could be up to 70, and they do interact with the environment. We'll discuss complex autoimmune disorders such as lupus, multiple sclerosis, and rheumatoid arthritis, and the genetic factors involved in that. And then we'll get into a discussion about Alzheimer's and other the age-related hearing impairment. So we'll go ahead and get started. Monogenic disorders, as we know, are single gene that codes for protein, codes for the wrong protein, or doesn't code for enough of a protein. We have alpha-1 antitrypsin deficiency, hereditary hemochromatosis, and MODY. We will talk about the first two in this lecture. We'll take a break and we'll come back and talk about diabetes and obesity. Some unique issues about all of these disorders is that they are usually multifactorial. Even if they are single gene, there's an environmental component. This is why you don't see it expressed earlier. And we're going to talk about the value of predictive genetic testing for these adult onset disorders. Some disorders, it's a little bit harder to predict whether or not somebody will get a disease because we haven't identified all the genes. Other disorders, it might be a little easier. There are factors like penetrance that come into play. Penetrance is the percentage of people who have the gene who will get the disorder. So sometimes there's a real benefit and sometimes the benefit is less clear. But we'll start talking about alpha-1 antitrypsin deficiency. So this was first described in 1963. The gene that is the culprit is the SERPINA1 gene. It codes for alpha-1 antitrypsin normally, and that's a good enzyme to have. If you have the abnormal alleles for this disease and you are homozygous, you got one from each parent, you have an extremely high risk of emphysema. And we'll talk about things to mitigate that risk, but you kind of have that target painted on your back if you have this homozygous pattern. AATD causes liver disease in some children. You might even see it in the neonatal period as well as in adults, but it's more rare to see that in children. And we'll talk about the pathophysiology of liver disease. So 90% of the patients that have this aren't diagnosed. They're walking around. They don't have enough AAT in their bodies, and slowly the protein trypsin, the enzyme trypsin, is causing damage to their lung tissue. Because we don't know they have it, they're not getting the intervention that they could be getting. And so this is a case where hopefully genomics will move forward and take a more prominent place in medicine and healthcare. And these are some of the things that can happen with alpha-1 antitrypsin. Mostly what you see here, the COPD, bronchiectasis, and asthma. And in liver, cirrhosis is the most common complication from that. Psoriasis is very common with people who have AATD, and it's usually pretty severe. Okay, so what's happening in AATD? How does it cause COPD? Well, healthy normal lungs have proteolytic enzymes, including trypsin, to break down the foreign stuff that you breathe. So bacteria, viruses, particles in cigarette smoke, particles in pet dander, pollen, all of those environmental pollutants that can get into our lungs, gases, asbestos, dust. So you need trypsin to break those down. But when you have too much of it, when it runs out of stuff to digest, it's going to go to work on healthy tissue. And that's what causes the problem. Now, the other problem is that when you make abnormal alpha-1 antitrypsin, remember a gene codes for a protein. This abnormal allele will code for the wrong sequence of amino acids, and the proteins get folded and they jam up the liver. So that's the other part of that disease. So if you don't have enough alpha-1 antitrypsin that is functional, eventually the elastic tissue of the lungs will break down. The alveoli will no longer expand and contract the way they should. They get kind of blown out, like, an elastic on underwear that's real worn out. And your misfolded proteins, the proteins that were inappropriately created by those abnormal genes, are going to build up in the liver and they're going to cause damage. So that is the pathophysiology of AATD. And here it is in a picture. So you don't have enough AAT functioning. It's all stuck here in the liver as a Z polymer. It's misfolded. It's not getting to the lungs. So the trypsin, the protease, is going nuts, and it's digesting everything, including healthy tissue. You get inflammation. Eventually, over time, this happens often enough for a long enough period of time, you will get emphysema because the elastin breaks down in the alveoli. Okay. In the meantime, the body might be trying to make alpha antitrypsin, but it's making the wrong stuff and it's folded, just like those sickle cells are the wrong protein. It's a different protein, but when they're folded wrong, they get stuck, and they don't carry enough oxygen to target tissues, and they cause pain and inflammation. So that is what happens there. Your aggregation, you don't have to get that complicated with it, but that's erythrocytes. You get inflammation all over your body, and that's what causes all the other things, the vasculitis, the psoriasis, all those things. So here is a picture of a person who has AATD related panacenar emphysema, and that's what that would look like. So there's a lot of damage there. You can see all of these airways are damaged. Here's how it works in genetics. Okay, so you have basically 3 alleles that code for the antitrypsin protein, the alpha antitrypsin. One of them is normal. That's your M allele. The S allele codes for a slightly less normal protein, and the Z allele codes for a very folded, like misfolded protein. So if you are homozygous you have 2 normal alleles. You will have normal AAT. Your risk is, not eliminated for COPD, but it will typically have a later onset and typically be slower to progress. If you have heterozygous pattern and your one allele is normal and your one allele is that Z that codes for the misfolded protein, you will have a slightly increased risk of poor lung function, but it's slight. It's significant, but it's slight. And it probably has to do more with your environmental triggers. SZ, you have 2 abnormal alleles, but they're not the same ones. You have a higher risk of lung problems if you're a smoker. You should make enough AAT from your S allele, but it won't be as good as MZ or MM. And if you have ZZ, this is the worst. This is associated with clinical disease and really low levels of AAT. You have the highest mortality from this, the earliest onset, and the more severe progression of disease. So, what are some environmental contributions? Environment is key when it comes to controlling the progression of the disease. If you are a smoker, you have a target on your back from your genes, and now you have added the match to that gasoline. So if you're a smoker with AATD, you have that ZZ genotype. You'll have symptoms of emphysema as early as your 30s. You may have had asthma all along. But if you are a smoker, you're a sitting duck. 80% of you with the gene and the cigarette smoke will have COPD. And you probably get it before most people would. Non-smokers with AATD might have symptoms after age 60, depending on their other exposures, but some won't have any lung disease. So that environmental trigger is really crucial. If you knew you had this, wouldn't you want to do something about it? And of course, we're going to counsel people to avoid active and passive smoking. Maybe all smokers should be tested for this genotype. It couldn't hurt. They're at risk. And we don't penalize people for having lifestyle factors that we don't agree with. So definitely, if you tell that person that you are really a sitting duck for severe emphysema and a much shorter life and a much lower quality of life, a lot of them would know to quit smoking, and they would be motivated to do so. Also, avoiding other pollutants, polluted air, dust, occupational exposures from gases or other fumes. We can help protect people. Wear a respirator mask if you're working around dust or any other kind of environmental chemical exposure. If you work with toxic agents, maybe use a hood. And then finally, we can actually target their symptoms with augmentation therapy. You can replace AAT. It's not cheap and it's not easy. It means a weekly trip to the infusion room. And it won't reverse pre-existing lung damage, but it can slow the progression of disease in people and offer them a longer and better quality of life. So where's the science headed with AATD? Well, a lot of specialists are recommending genetic testing for and polygenic risk scores, like, looking at all different things along the genome for people at risk. They're not recommending newborn screening. Definitely anybody with obstructive lung disease, liver disease of unknown origin, or a relative with known AATD should be offered testing. It is not as expensive as other options and certainly cheaper than a lifetime of care if you can reach people before the disease progresses to the point where they've got significant impairment. Research supports genetic counseling for people with AATD to help them understand lifestyle modifications in relation to their risk. So all of those things kind of support counseling and testing. If you are known to have AATD-induced lung disease and you are still exposed to tobacco smoke, there is some research using certain antioxidative therapies, including N-acetylcysteine or NAC, to help repair the damage caused by the trypsin in response to tobacco smoke. Augmentation therapy enhancements, ways to make it cheaper and easier. They're looking at sourcing it instead of from donors, which is the current practice. Cost for, I think, one person is about $82,000, I think, over the course of a disease. They think they can maybe source it a little bit more cheaply and easily with E. coli bacteria. There are two medications under investigation. One is carbamazepine, which is also known as Tegretol. It's an anti-seizure med, but it does seem to have a protective effect on lung tissue, and rapamycin, which is a cancer drug that is being investigated for this. They do seem to have positive effects, at least in laboratory animals. And then they're looking at interference mRNA to lower trypsin levels. Lastly, the CRISPR technology that you guys learned about in epigenomics is being applied to the faulty gene that's involved in AATD. And we're looking at, or scientists are looking at pluripotent stem cells to see if they can regenerate or, add some of that antitrypsin, alpha antitrypsin. So let's look at it in clinical context. I can't do this for every disorder because it'll take forever, but let's just think about how genomics can be applied to help people. So you're caring for a client during a routine annual physical exam. You collect data on family history. Several family members have a history of COPD. Don't write it off and say, oh, they were all smokers. That's what happened, especially if you see that most of them were diagnosed at relatively young ages. Client smokes a half a pack a day. His partner smokes. He reports mild asthma that gets worse when he gets a cold or other respiratory infection. Um, and he's exposed to a lot of particulate matter through his job, asbestos dust, um, maybe chemicals. So, what are the implications for this person? Well, at the moment, he probably would not be offered genetic testing, but that may change. And hopefully it does, because if he is positive for AATD, that information can be used to counsel him on the importance, especially for him, of quitting smoking, reducing his other environmental exposures, increased surveillance. Maybe we do lung function testing on this person a little bit more often. Maybe we look at liver enzymes more frequently to make sure that he's not developing irreparable damage. Preventative health care. I mean, everybody should be offered the influenza vaccine, the COVID vaccine, the pneumonia vaccine, but this guy's really at risk. Um, and if he's just coming in for, like, say, a work physical, this can be your opportunity to open that conversation about those vaccines so that he understands that he can't afford to damage his lungs with this genetic tendency. And if he acquires COPD, despite all of your best efforts, he gets emphysema. What treatment options can we offer him? In addition to bronchodilators and inhaled steroids and oxygen therapy and activity modification, what other things can we do to help him? I mean, would he be a candidate for AAT replacement? Would he be a candidate for any of these other therapies that are coming down the pike? It's just sort of an interesting case to think about. Very tiny discussion of hereditary hemochromatosis, actually a very common gene, but because of decreased penetrance, meaning penetrance is the percentage of people who carry the genotype who express the trait. In hereditary hemochromatosis, only about 40% of the people who carry the gene will actually go on to store excess liver in their tissues. So there's multiple factors involved here. So what hereditary hemochromatosis is? It's a single gene disorder that involves excessive absorption of dietary iron by the gastric mucosa. So it's a little more permeable and it sucks up the iron, and then it kind of stores it inappropriately in the liver, pancreas, heart, joint, skin, sometimes testicles. Onset somewhere in middle age, almost exclusively Caucasians, highest in Northern Europeans. It can happen to women after menopause, commonly because they're no longer losing blood through their monthly cycle. So that's why we see sometimes that later onset with women. Symptoms in the beginning are vague and mostly have to do with liver damage, weakness, abdominal pain, and weight loss. You can see joint pain as it accumulates in the joints. Eventually, the iron deposits in the heart will make it harder for the heart to work, and you'll end up with heart failure. So, single gene, there are 5 mutated alleles that are responsible, and all of them except one are autosomal recessive. So you usually need to be homozygous, or what they call compound heterozygous. This is a new term for you. So homozygous means you have 2 alleles that have the same mutation and make the same bad protein. Or compound heterozygous, meaning you have 2 alleles. They both make bad proteins, but they make different ones. They are different alleles, different mutations. Incomplete penetrance, some people will carry this genotype and they don't get it. And some people will get the full-blown disease. About 40% of people who carry the genotype will actually end up with a diagnosis of HFE-HHC. Is your patient clinically affected? Well, how would you know? They may come to you with symptoms, or you might catch it on routine blood work. This patient always has a high CBC, high hemoglobin hematocrit. And that coupled with, the other signs and symptoms, weakness, joint pain, abdominal pain, could tell you that that person is storing iron inappropriately. You can have carrier testing done. It's actually in those direct to consumer marketed tests like 23andMe Health Panel, it's included in that because it is very common among Northern Europeans, especially Scandinavians, Irish, British. Predictive testing can tell you who's at risk. And since the surveillance for that is a simple CBC, it might be worth it to have that testing done. The treatment is also really inexpensive and can prevent a lot of damage throughout the body tissues. And it's simply phlebotomy. You just take blood from this person. That's why premenopausal women often don't have HHC, because they're kind of eliminating that excess iron through bleeding every month. Without treatment, you can get excessive iron in the tissues. We already talked about fatigue, joint pain, abdominal pain. But the bad stuff is that eventually these iron deposits will lead to defects in the pancreas with insulin secretion, liver function, and heart failure. You can see hypopituitarism, which will kind of mess with a lot of different hormones. Arthritis, obviously, if you have iron deposit in your joints, it's going to help them degenerate faster. But cardiomyopathy would be the most serious complication of that. So it kind of pays to predict that disease and offer somebody the cheap and easy treatment of therapeutic phlebotomy if they need that. And to just monitor their blood levels. But that's sort of one of the applications of genomics. We're going to take a break here and move on to diabetes